Alterations in elimination, gastrointestinal, ostomies. An ostomy is an opening between an internal body structure and the skin, usually the abdomen. There's different types. We have an ileostomy. This will go into the small distal intestine. And we have a colostomy, which is going to go into the colon. The stoma is defined as being the opening, so it will be what we see on the abdomen. Ostomies are created due to inflammatory bowel disorders, rupture of an intestine, an irreversible obstruction, or a compromised blood supply to the intestine, or a tumor. A matured stoma is going to be nice and pink or dark red. It's the skin around it should be nice and healthy skin. Um, it does take a little while to heal. A new stoma is actually going to be slightly edematous. It may have scant or very minimal bleeding because what we're actually doing is they are bringing a portion of the intestine out through an incision made in the abdominal wall. And then they're kind of folding that backward and they're suturing it to the abdomen. So a little bit of bleeding, very, very small amount, is normal. The fecal matter that comes out of an ostomy is going to be liquid to really soft. There should not be a lot of form in it. Depending on the placement of the ostomy will basically direct what type of stool will be coming out of it. So if it is coming through the um, small intestine, excuse me, then it will be more liquid. The closer it gets to the rectum, the more normal type stool we may have. So the more form that might be to it. We are going to cover that ostomy and stoma with an appliance. This appliance usually has kind of a Caraya gum paste to it, which is the adhesive, and it should adhere very well to the client's skin. It is also going to offer protection to the skin. Caraya gum or the Caraya paste is going to be more effective if we, after placing it around that stoma, put our hands around it and use body warmth to help improve that seal. So you basically put the appliance on, then you're going to keep your hands kind of wrapped around that stoma using the heat of your hands to help improve the seal for a couple of minutes before you move your hands. True or false? A colostomy is a surgically created opening between the small intestine and the skin. This is false. This is going to be in the colon. So the ileostomy may be temporary or permanent, depending on the reason that the ostomy was created to begin with. We have different types of ileostomies that may be used. We have the standard or Brook ileostomy, which is conventional. It does involve a total colectomy. The fecal matter will be very liquid, mushy, or pasty. We have a continent or abdominal pouch, which would involve the creation of an internal reservoir that is removed periodically with a catheter. We have an ileoanal reservoir, which maintains bowel continence. It may be performed for, let's say, chronic ulcerative colitis. It would be done in two different stages. A temporary ileostomy would be performed, and then 2 to 3 months later, the ileostomy would be reversed. So, preoperatively, we should consult the ostomy nurse for postoperative care, and we have to cleanse that bowel. Postoperative, we're going to do normal care. These clients are probably going to have an NG tube for a day or two, definitely intravenous fluids, and potentially antibiotics. As always, we would monitor for complications. And then we need to educate the client on ostomy care, how to change the appliance, when to change the appliance, etc. Again, the appliance is a collection device that is worn over the stoma, and they come in a variety of um, different shapes and etc. So we can have the disposable, and it may be just a one piece, it may be a two-piece device. If it's a two-piece device, then basically we have the ring that fits around the stoma that has the Caraya gum, and then it has kind of like that uh, Tupperware seal, so to speak, where we fasten the bag on to the ring itself. We can use a temporary. That's what's going to be preferred in the immediate post-op phase. There are reusable devices that involve an O-ring on the faceplate. Again, just so we are just replacing the pouch and not the entire appliance. Um, it just depends on if that faceplate is leaking the contents or not. They do come with some rings around them, so you can attach a belt to provide a little bit of support for the weight of the pouch. We encourage that these clients empty it when it's about 1/3 to 1/2 full to prevent too much weight from pulling. Again, that adhesive seal is going to seal better with body warmth. So putting your hands on that Caraya gum to allow that body warmth to create a better seal. Make certain that the hole for the stoma is not too large. It should only be approximately 1/8 of an inch larger than the stoma. These face plates are going to come with a little ruler that you can use of varying sizes of ostomy openings, and you can use that to kind of place it over the client's stoma to determine which is the appropriate size. Then you can draw a circle on the back of the faceplate and then cut it. If you do have to cut the opening larger, then use your finger to run it around the inside of that opening. Again, body heat is going to help with adhesion, but it's also going to help smooth out any potentially sharper edges from the Caraya gum. So again, make sure you run your finger around it for a minute or so to kind of smooth out the cut edges. Initially, after an ostomy is placed, a lot of these clients are going to have some gas beginning to work through the gut. They're not going to have much stool at this point, And it may be necessary to burp the appliance. So basically, that just requires unclamping it and removing the air. We also know that the initial effluent, EFFLEUNT or UENT, uh, may be pretty mucousy. It may be a little pinkish in color, but then it kind of turns brown. Excuse me, and then it may be liquid initially that comes through, even if it is a colostomy. Again, we cut that hole only an eighth of an inch larger than the stoma itself because the abdominal skin is not designed to accommodate feces. And feces can be very excoriating to skin that is not accustomed to being in contact with it. So we can have some significant skin impairment if we start cutting it too large or if it leaks too much. And if we have those issues with skin impairment or leakage, always consult the ostomy nurse. So preoperatively, again, we're going to let the surgeon discuss the surgery itself, the purpose, the benefits, risks, etc. They should also kind of discuss what the stoma is going to look like and about where it will be on the abdomen. Nurses can reinforce that education. There are some interstomal therapies, and there are some nurses that specialize in stomas, the ostomy nurses that would be very good to talk to these clients. They might be a wound ostomy and continence nurse, or they may just be an ostomy nurse. They kind of collaborate with the surgeon and make sure that the client's educational needs are being met. Now, in some of your smaller facilities, you may not have these nurses, so this may be something you need to learn to take care of on your own. It is important to identify risks from a total colectomy, such as bladder and sexual dysfunction. If there is some sexual dysfunction, we may need to collect and store sperm. It only slightly diminishes fertility in women. Again, cleansing of the bowel prior to surgery. We don't want any feces to be in the intestine when we cut it open. It's going to increase the risk for infection. And this can be done with a combination with a laxative or lavage agent. Um, there may be an antibiotic prophylaxis, oral or IV. It is important to taper and discontinue prednisone if the client takes this routinely to avoid any negative effects on tissue healing. Also, preoperatively, there might be a stress dose of an IV steroid to prevent an adrenal crisis if a client normally takes a steroid. It is important to discontinue any immunosuppressant agents if at all possible to prevent that negative effect on tissue healing. Clients should discontinue any medications that would increase the risk for bleeding, such as aspirin or any antiplatelets or any anticoagulants. And we definitely need to obtain blood samples and do type and cross match for potential blood transfusion postoperatively. Postoperatively, some clients may have a rectal pack to absorb drainage. This would stay in place for a few days. There may be some irrigations going on to promote healing or a nasogastric tube to decompress the gastrointestinal tract. IV fluids, for certain, to maintain fluid, electrolytes, and nutritional balances. Antibiotics or analgesics, definitely. We need to monitor wound healing. We need to monitor the stoma site. If we see anything other than that slightly edematous, nice, healthy pink color, then we need to be contacting the surgeon because there might be an impaired blood supply. That stoma should be protruding from the abdomen. It should not be uh, inside the abdomen, but we want to make sure it's not protruding too much. Again, if there is too much edema, it may cause obstruction and it can mess with the blood supply. If the stoma becomes necrosed, then this client's going to end up going back to surgery and they're going to be very sick. True or false? Discontinuing the use of aspirin before surgery will decrease the likelihood of excessive bleeding. And we know this is true because of the aspirin's antiplatelet properties. True or false? A Coke pouch is used to facilitate a continent urostomy. This would be false because it's going to be used to facilitate a continent ileostomy. A urostomy is actually going to be a stoma for urinary drainage. So with the colostomy, this is going to be an opening in the large bowel. Again, the fecal matter will be semi-liquid to formed. The closer it is to the rectum, then the more formed it will be. It can be placed because of that cancerous lesion, the ulcerative inflammatory process, multiple polyps, or injury to the bowel. Again, it may be temporary, it may be permanent. It can go anywhere in the large intestine, the ascending, the transverse, the descending, and even the sigmoid colon. Sometimes irrigations are done to help control the effluent. Uh, Sometimes they're done to, uh, if the client is having some constipation. There are different types of stomas that may be done. It may be a single barrel, it may be a double barrel. If it's a double barrel, then basically we have a couple of loops that are being used. Single barrel is just usually a segmental resection. So true or false? A colostomy can be either temporary or permanent. This is true.